Okay, let us begin our webinar. Good afternoon, everyone. Welcome to our weekly webinar organized by the College of Physicians Malaysia. Theme of the month is nephrology, and with us today we have our chairperson, Dr. Ong Chun Seong. A few words for Dr. Ong. He obtained his master's in internal medicine from UM in 2014 and specialty training in nephrology from KKN in 2018. He's currently a consultant nephrologist in Pantai Hospital, Cheras. Dr. Ong has actively involved in trials and research and has published numerous papers pertaining to nephropathies, peritoneal dialysis, and transplant. Without further ado, let us welcome Dr. Ong.
Thank you, Dr. Kelvin, for the kind introduction. Good afternoon, my fellow colleagues. Thank you for joining this weekly webinar organized by the College of Physicians Malaysia. As we all know, acute kidney injury is very common. It occurs commonly in the hospital setting, and unfortunately, one of the most commonest cause would be iatrogenic. In lower income countries, acute kidney injury occurs in the community as well. And despite sometimes we have full recovery of the kidney function following acute kidney injury, it is not as harmless as we think it might be. Today, I'm very pleased and honored to have Dr. Primella to share with us regarding acute kidney injury. Dr. Primella is a consultant physician and nephrologist working currently in Thomson Hospital, Kota Damansara. She graduated with her master's in internal medicine in 2016 and subsequently completed her nephrology training in 2022. She has numerous peer-reviewed journals under her name. And without further ado, I would like to invite Dr. Primella to share with us regarding acute kidney injury. Prem, the floor is yours.
All right. Thank you, Dr. Ong. Thank you for the very kind introduction. So good evening to everybody who's participating today in this webinar. So I'm going to speak a little bit about acute kidney injury, and then just a few thoughts of mine that I would like to share here. Okay, so to begin with, all right, so this is definition. When you look back at the definitions, a long time ago where CKD definition was first introduced in 2002 by Kedoki and adopted by KDIGO in 2004. And over 10 years of AKI, KDIGO guideline came out with the AKI guideline. So they consider AKI as a subset of AKD. And then in 2016, Acute defined AKD and felt that AKI preceded most of the AKD. AKD is acute kidney disease here. And in 2020, KDIGO harmonized all these definitions. So this is a very familiar chart to all of us here. So this was by KDIGO guideline, whereby they have characterized or staged AKI based on 3 stages based on the serum creatinine and urine output. But what you have to remember here and bear in mind is this criteria is to be applied only after optimizing the volume status and ruling out urinary tract obstructions. So what exactly is acute kidney injury? So we know that it's a heterogeneous syndrome describing an acute reduction in GFR as per definition of KDIGO criteria. So you have whereby the creatinine may be increased about 50% in 7 days, or based on the urine output of less than 0.5 mL per kg per hour for 6 hours, and in worst case scenario, whereby there would be initiation of the kidney replacement therapy. So with the asterisk down here, of note, there had been several biomarkers that has been tested for at least about 10 to 20 years now, trying to refine the definition of AKI, but unfortunately, none of them had successfully exceeded the creatinine capacity as a prognostication marker of AKI. Hence, most of them are being largely used in clinical trials and research. And hopefully in future, we may be able to use these biomarkers to risk stratify and prognosticate AKI. This is the current thinking of AKI, AKD, and also CKD. So we know that the AKI was based on the creatinine level, and then came AKD. So beyond 7 days, they came up with a term AKD. And why was this term introduced? Because they wanted something to bridge between the AKI and also chronic kidney disease, or CKD. And the definition that was proposed for AKD was similar of AKI with the severity staging, and beyond 90 days, then it has revolved into CKD. Moving on to AKI incidences. Okay, so this was taken from the meta-analysis across worldwide. So you can see in the high-income countries, so the incidences of AKI was fairly quite consistent. You can see North America about 22.3, Eastern Europe about 23.8, Western about 20.8. The characteristics of AKI in high-income countries were rather quite different. This was based on age, financial burden, the health services that was being provided, ICU settings, for example. And it was definitely very different as compared to the low and also middle income countries, and especially when kidney replacement therapy was needed. Okay, so we know that it's going to cost these countries quite a bit. AKI in high-income countries, the characteristics of them, they were predisposed if you were elderly, you have an underlying heart diseases, kidney diseases, diabetic even, and even if you would have had a longer ICU stay, undergoing some surgical interventions, exposed to certain drugs, sepsis, and also exposed to contrast. Moving on to this AKI epidemiology, you can see it occurred about in 1 in 5 in hospitalized patient, 1 in 2 or 2 in 3 to those in ICU, 1 in 5 in those undergoing cardiac surgeries, 1 in 20 to 1 in 2 in those who were septic. So this was based on severity and also severity of the AKI itself. But what was alarming here? So it is expected to double over the next decade. So this is very, very alarming for all of us. Moving on to the AKI epidemiology, pathophysiology. So I think it's important for us to know how acute kidney injury occurs. So you know about 20% of the cardiac output goes to the kidney, and there is a fair distribution to the cortex selectively. So this is where all the glomerular perfusion and also filtration occurs. So when there is an effect on this blood flow towards the cortex, so that is when acute kidney injury will be predominant. So we know that AKI is a heterogeneous syndrome. So it's not a single disease entity, and there are several potential mechanisms that can contribute to this injury. So in a single patient, there can be either one dominant main mechanism or even several mechanisms. So these mechanisms can be broadly classified into, the first one is inflammation. So there can be some activation of adaptive immune system leading to pro-inflammatory milieu or even cytokine release. And then there could be an alteration in the macro and micro circulation. So it's resulting from a hypovolemia, or conversely, it can be hypervolemia causing some congestion. And at the microcirculatory level, there can be multiple dysfunction, including the angiotensin signaling. In terms of metabolic reprogramming, so there will be a reprioritization of energy expenditure. So all these were very well described, especially in the animal models. And then we looked into cell survival as well. So what am I showing you here? So we know that it is not only the dominant mechanism, all right, that varies between patients after a particular insult, but I'm trying to show you here that it can vary in an individual patient across their time course. So what am I, example here, sepsis. Sepsis is a very good example, meaning that when patients who are in sepsis at the beginning, they can have a trajectory of pro-inflammatory milieu. And then over the next couple of 2 to 3 days, so they can have a predominantly anti-inflammatory cytokine release. So this makes it rather quite difficult for us to test therapies with anti-inflammatory with this different group of patients. We currently do not have in real time what the predominant mechanisms are. Okay, so we know that it can be inflammation, we know it can be macrocirculation, microcirculation. But we used to previously classify AKI based on etiology. Example, it can be sepsis AKI, cardiac surgery AKI. But what is increasingly being recognized is that different etiologies can actually have the same mechanism at play, as how you can see it on the left here. So we should be able to test certain targeted therapies. For example, sepsis again. So someone who is in septic shock or sepsis can be febrile, they can be hyperdynamic, they may have a vasodilatory circulation. But similarly, if a patient after a cardiac surgery, they're going to possess the same features. So we felt at this point of time, this is a relatively quite a novel approach, but we felt that treatment can be used for different group of patients of different etiologies. And I think that over the next 5 to 10 years, we are more likely to see more trials which are enriched in classifying patients into different subphenotypes. So within AKI itself, we can identify several phenotypes again. So there were lots of phenotypes that they looked into. So number one was severity. So based on AKI severity, whether it was stage 1, 2, 3, based on duration, whether it was transient, less than 48 hours, or whether it could be beyond 48 hours up to AKI, 7 days, AKD, and then they prolong further to CKD. And all this was based, and lastly is frequency, meaning whether it's a single episode or it is a recurrent episode. So they felt that each one, and as you can see, each one of this phenotype carries an important role for prevention of further AKD or progression to CKD and even death. One of the good examples here is a perioperative AKI. So I guess a lot of us nephrologists, we tend to deal with patients post-surgery, or what you can see, there will be a pre-renal, that is renal hypoperfusion. And then intraoperative causes, you look into IABP or even cardiopulmonary bypasses, post-renal causes, rule out any other risk factors as well. Risk prediction for AKI. So we know there are a number of well-established risk factors for AKI. Example, older age, gender, if you have underlying CKD, underlying heart diseases, diabetes, surgeries, certain medicine that can be used, sepsis, hypotension, hypovolemia, even other parameters, for example, hemoglobin, that is anemia, and also albuminuria. So what really happens when AKI takes place? So this is going to be the effect of AKI. So we know that the very minute AKI occurs, so there's going to be an abrupt loss of kidney function. So you know that all the function of the kidney, example, retention of nitrogenous waste, are going to occur, dysregulation of extracellular volume, electrolytes, acid base, and balance. This is something that I would love to share with everyone. Okay, AKI and acute kidney failure, or formerly known as acute renal failure. So the question I'm putting up here is that, is this the same or not? What are the similarities and the differences here? So we know that when AKI takes place, there will be a reduction in renal function, and this is going to be a marker that there would be an increased risk of mortality and morbidity. Whereby AKF, on the other hand, or acute kidney failure, acute renal failure, is a small subset from AKI, meaning that these are the more severe patients who come in who might be needing dialysis. So why these two different terms? So when we use the word AKI, acute kidney injury, we tend to pick up patients faster. We tend to identify this group of patients faster and try to manage them before it gets a bit later. But if we are only focusing on acute kidney failure or renal failure, we might be too late to avoid certain complications. Moving on to how do we detect kidney injury? So very easy, these are basics. So some of us look at the serum creatinine. The criteria says it's serum creatinine. Some of us are good at measuring the GFR. We look at the creatinine clearance. Some of us use different kind of equation to calculate the eGFR, that is the estimated GFR, and not to forget a declining urea output. So creatinine and GFR. So something interesting that I want to share here. So as you can see here, I want to ask you this. So what's wrong with creatinine? So what creatinine really does is that it lags behind the actual GFR changes. So if you can see in the picture, So at least you have to have a reduction of more than 50% of your glomerular filtration rate before the creatinine slowly rises up. So this is what I say by lagging behind the actual GFR changes. And so in the early phase of AKI, creatinine practically overestimates the GFR. And in the recovery phase, as you can see now, the GFR will be quite variable, and so is the creatinine. So it underestimates the actual GFR. And we know that creatinine is being influenced by a lot of factors, right? So one definitely is removed by dialysis. So after a dialysis session, do not order to blood investigation just to look at the creatinine level, but I rather order for other electrolytes or acid-base bicarbonate level or a VBG, for instance. And it all depends on muscle mass. Okay, so this cannot be used or has to be carefully used in those who are elderly, those who are malnourished, female, children, those who are amputees, those who have liver diseases. So you know that the muscle mass is going to influence the creatinine level, and not to forget that it can be affected by hydration. So why hydration? When a patient comes in being hypovolemic or having AKI, the first thing that runs through our mind is to pump a lot of fluid in. So we are going to artificially create a lower creatinine level. So if creatinine does not seem to be the right thing, then how about GFR? So what's wrong with GFR? You know, in order to measure GFR, it has to be measured directly. So it's time consuming, it's expensive, it's not cheap, and it is quite tedious to be done. And let's see if I say that now I want to use eGFR instead. So I want to use all the different equations. So again, I've mentioned it, creatinine lags behind the actual GFR, meaning that my calculation of eGFR based on that creatinine is also going to lag behind the GFR. And for us to use these equations, bear in mind that it can only be used when the creatinine is in a steady state and not to be used in AKI. How about the next criteria that has been volunteered? Is the urine output. Why not the urine output then? So patients don't really notice until it's too late. And whenever, let's say, for example, we go to ICU settings, we see a patient and then we see transient fluctuations of urine output. So we feel that it's not clinically significant unless it's a sustained, it's the same reduction. And there's this entity that we call as non-oligouric AKI. So we are happy. There's urine, there's a bit of AKI, so we don't really take them very seriously. And we know that urine output monitoring can be difficult outside ICU. This is something that I want to remind everyone again. Whenever we calculate the urine output, so make sure that we calculate it based on the ideal body weight and not their actual body weight. So this is very much applicable to those, for example, if they are obese, then BMI is more than 30. So please make sure that you use the ideal body weight for calculation. And obviously, you know, when there is lots of administration of diuretics, so it's going to falsify the urine output that is being produced. So I know that KDIGO has practically stated that the urine output of less than 0.5 mils per kg per hour for at least 6 hours. But there were a group of them who also looked into less than 0.3 mils. So they felt that maybe this number was more predictive of AKI, but I guess we're still sticking to the 0.5. So what has been again recommended here? So let's say if you have both the criteria of creatinine and the criteria of urine output reduction, so the death and dialysis may be of the highest level. But how if you have one criteria which is only, for example, at stage 1 of severity and the other at stage 2, so it is best for us to consider them as of the least favorable stratification, meaning that we just label them as a stage 2. So these diagnostic criteria, are they perfectly imperfect? No, because whenever they come in with AKI, patients come in with AKI, there isn't much information on the etiology of it, and we need to look back at the baseline creatinine. So these are all very practical things that we do every day in our lives. So what exactly is a baseline creatinine? Number one, if the patient does not have any previous admission in your hospital settings, so you take it the one on admission. If they do have previous admission right up to a year, so take an average value. There were a group of nephrologists who also say, let's assume everybody had a normal GFR, so you calculate backways. All right. But this, again, using the baseline creatinine, does come up with a high false positive of diagnosis of AKI when the creatinine is more than 1.5. So 1.5 is about 133, 134. Okay, example of this. Let's say if someone comes in with AKI, with creatinine, you say that creatinine is about 250, example. 3 days or 2 days down the road, it increases to 230. So the question here that we have to think back is this really AKI? Or is this just a false positive increment of creatinine? Again, look into all factors that may influence on the creatinine, including something called creatinine variability. So you need a few readings of creatinine before we want to say that this is actually AKI. Moving on to investigations, these are all very basics. So you want to look at your renal profile, you want to look at urea and creatinine. So for me, I just want to emphasize here, when you see someone coming in with urea, which is markedly elevated as compared to creatinine, then you think about whether this could be pre-renal, a GI bleed, for example, hypercatabolic state, or steroids. Why in GI bleed? We always say, oh, patient upper GI bleed, so urea is high. But it's good for us to know why the urea is being elevated in an upper GI bleed. Because you know there will be an increment of the ammonia genesis, there will be lots of catabolism of it because of loss of all the amino acids within the red blood cell itself. Okay, example coming in for rhabdo now. So if you see the creatinine, because rhabdo is going to be breakdown of the muscles, so creatinine is going to be much higher as compared to urea. And the rest of it, I don't really have to say much: sodium, potassium, calcium, phosphorus. This is something that we see day-to-day basis. Whenever we get the opportunity, please send in the urine for analysis and also to look at CAS. So as you can see, from these urine sediments, you can see dysmorphic RBCs. Then it gives you a rough idea whether it could be a glomerular pathology. And then these are the rest of the CAS, muddy brown CAS, which shows ATN, RBC, again, glomerular diseases. White blood cell CAS is pyelonephritis. Not to forget, for us to actually get an ultrasound of the kidney. Why? Because we really want to rule out any obstruction. All right, so time is kidney when it comes to obstruction. We need to relieve the obstruction as soon as possible before the injury becomes irreversible. But is there something else that we can actually see from the ultrasound? Yes, it does. So you can see whether it's a small size kidney, shrunken kidney, whether there's any form of scarring, loss of cortical medullary differentiation. So all this practically gives us an idea whether the patient who came in for AKI is solely AKI or has a pre-existing chronic kidney disease. So these are for exam goers, right? So this is a fractional excretion of sodium, which I don't really routinely use in my practice because it comes with a caveat. There are certain circumstances that you cannot use a FINA, or you have to be good at analyzing the fractional excretion of sodium. So here you can see in a pre-renal cause, less than 1% of FINA, and if it's ATN, it's going to be more than 1%. Just to give you an idea about why, instead of just remembering the numbers, for example, pre-renal, less than 1%. Why? So it's good for you to understand the pathophysiology behind it. So you know when someone comes in pre-renal, likely to be hypovolemic. So there was going to be RAS activation. So what does the kidney do now? It's going to reabsorb sodium, and along with it's going to be water. So the amount of sodium that's going to be excreted is going to be much lower. But remember I mentioned about the caveats that we have here. So if someone is on diuretics, so we know that the pre-renal AKI, fractional excretion sodium may not be less than 1% anymore. And even in those group of patients who have lost the concentration ability, for example, CKD, glycosuria, so all that is not going to be effective. But for those who are going for exam, you need to know this. Similarly, it's for urine spot sodium, urine osmolarity. Again, as I say, if it's pre-renal, what happens when the sodium is being absorbed, water follows along with it. So you have less sodium and you have increased concentration of the urine. Again, it can be affected by diuretics and the different levels of urinary concentrating ability. how do we differentiate between the different causes of AKI? I just want you to pay attention to the top three and to the lower three. So everything starts with history. History taking is very important. Again, this is urine output that we are talking about. But the one that I need you to really pay attention is to the response to volume repletion. So once you know that you have replaced enough volume, and if you see an improvement in urine output, automatically, you know, it falls under pre-renal, and the other two of ATN and post-renal may not be responsive to volume. But how about whether to differentiate between AKI or CKD? So this is actually my cheat sheet now. Okay, so obviously duration is important. You know, AKI, shorter duration, CKD will be more than 3 months. Oligo or anuria, that will be in AKI, unless it's going to be that entity called non-oligouric AKI. Patients are usually very sick when they come in for AKI. But if you have somebody with markedly elevated urea creatinine sits right in front of you and smiling at you, so I really think you should consider CKD. But one of the most important features here is going to be nocturia. I never fail to ask my patients with CKD whether they have nocturia. Most of them will, but that does not happen in AKI at all. And sometimes you can hear people say that, oh, you know, calcium is low, phosphate is high, so most likely this is CKD, but it's not. It can also occur in AKI, but anemia, on the other hand, might be a better parameter for us to look into. Those who come in for AKI, unless they're having upper GI bleed, then the hemoglobin may be normal, or maybe even slightly elevated because they are hemoconcentrated. But in CKD, most of them may be anemic, especially normochromic normocytic anemia. So my next question and next discussion is going to be, do I biopsy everyone who comes in for AKI? There are clinical indications. Example, prolonged AKI. If someone has been dialysis dependent for more than 2 weeks and you don't know what is really causing the AKI, then I would actually put in a needle for them. Those suspected with RPGN, AIN, those are the group of patients that we should biopsy, and AKI with systemic features, just to make sure that this is not vasculitis, this is not autoimmune diseases that we are dealing with. This is exactly how the biopsy is going to look like. So in ATN, you see all the necrotic cells will be within the tubules, and cortical necrosis is all ghosted out here. Management. All right. We live in an era now where we have no specific targeted therapy for this clinical syndrome. We have no effective therapies, so our guidelines have not prescribed how our AKI should be managed. So overall, it is going to be just supportive care. So it's really all about supportive care. Example, removing the further insult. So you discontinue all your nephrotoxic agents, check drug levels, doses, optimizing renal perfusion, one of the utmost important factor here, and reverse any of the biochemical derangements, meaning that potassium, sodium, calcium, and renal replacement therapy or a kidney replacement therapy. To be honest, instead of calling it as kidney replacement therapy in AKI, I like to call it as a kidney support. All right, so kidney replacement therapy, once you say kidney replacement, a lot of them will be thinking about long-term effect of the therapy. So again, general principles. Do not forget to assess volume status at admission, monitor BP, urine output. Best way to actually look at fluid status is to check weight on daily basis. Plasma glucose is supposed to be between 7 to 10. Do not starve your patients when they come in for AKI. A lot of us, again, are with the understanding that it is similar to a CKD stage 4 or 5 or approaching end-stage kidney disease. So they need a bit less of calorie and a bit less of protein. So do not do this because they are in a very hypercatabolic state. And even if they are non-catabolic group of AKI, they're going to need the protein because they're going to have a lot of losses when we start dialysis on them. Okay, so this is something for you to understand. Okay, so that's why I put it up. So I like a little bit extra about physiology so that you really understand what BP management is all about. We always say we need to optimize the volume status. We say check the blood pressure. In ICU setting, in elsewhere, we always say keep a mean arterial pressure of more than 65. So my question here, does it apply to everyone? So I'll answer you in a bit. So our kidney, our nephrons are able to auto-regulate as long as the blood pressure is between 80 to 150. So you know that the efferent arteriole is going to have prostaglandin that's going to cause a vasodilation. And the other part of it, the efferent, is going to have a vasoconstriction because of the angiotensin 2. So overall, it's going to reduce the GFR. And the reduction of GFR may be a good feedback mechanism later. But here in ICU settings or any other settings where AKI is, there can be compounded with more insults, NSAIDs. So it's going to inhibit the prostaglandin now. And then you have ACE or ARBs that's going to inhibit the other side of it. So what happens? Overall, GFR drops quite badly. Okay, severe hypervolemia can cause the loss of the autoregulation. So once the kidney cannot cope anymore with this autoregulation, there will be a significant drop of GFR. Again, are all group of patients the same? No. Those who are elderly, diabetic, hypertensive, CKD, automatically we know that these are the group of patients who will lose their autoregulations. So what do? Do we fix them at a MAP of 65? No. We actually fix them at a higher MAP, for example, 80. Next, moving on to the potassium. So we all know AKI related to hyperkalemia, and then we give all these agents of lytic cocktails, nebulizer and all. And then we often get this call, let's say if we have dialyzed someone. So we feel that potassium has not been cleared out well. So is dialysis a good way of removal of potassium? I would say yes, but not if multiple lytic cocktails have been given before that, because what we are doing really is by giving all these agents, whatever that is in the plasma, the potassium, we are just going to push it temporarily into the cells. So what the dialysis is going to do is just going to remove whatever potassium that is in the plasma. So then that is how you have a rebound effect. Okay, so I would say it's quite a less efficient way. But am I trying to say do not give any lytic cocktails before you call any of the nephrologists in? No, you need to do what is life-saving for the patients. So what we would do on the other hand is going to be increase the frequency of dialysis until we are able to contain the amount of or the level of potassium that we need. Again, metabolic acidosis, you can give sodium bicarb once pH is more than 7.2, meaning that it goes into compensation. You can actually stop sodium bicarb. Avoid any fluid overload. So if there is, then you have to decide whether it's diuretics or dialysis straight. Some of them, we have given enough volume. So, but despite giving so much of volume, you know that the urine output is not improving. So this is something that we call as volume unresponsive AKI. So from a volume unresponsive AKI, most of them will be kept on given fluids that's going to cause overload. And what does overload going to do? It's going to increase the time of patients being on the ventilator, increases mortality. So we need to have a very prompt decision on what needs to be done now. Either you try with diuretics or you dialyze the patient. Furosemide stress test. Okay, so I kind of like this, and I've tried this on quite a number of our patients. So it kind of predicts the requirement of dialysis, meaning that you are giving fluids, but you don't see enough urine output. You don't know whether you want to start off your dialysis immediately. So this might actually help a little bit. What do? You give a bolus dose of furosemide, about 1 milligram per kg if never been on diuretics before, or you give higher dose of 1.5, and then what do you want to see? So it is considered responsive if it's more than 200 mils of urine in 2 hours. So meaning that you still have a bit of time to buy before you decide on moving on to the next step. Okay, but there were a group of Japanese researchers who felt that we should use the term furosemide responsiveness instead of whether fail or goes on with the furosemide stress test. This is because, okay, every individual varies in their own different ways. So there's individual variability. So is it right for me to say that everyone should pass out the same amount of urine of 200? No. So furosemide responsiveness, what they did was whatever urine output which is produced in 2 hours after the diuretics, so they divided by the furosemide dose, and then anything less than 3.9, they said that it can actually predict dialysis and death. Next thought that comes to mind is how long before ATN recovers, okay? When you have an acute tubular necrosis, so you know less severe injury, shorter duration, so it's just all because of rearrangement of cytoskeletals and all. So it can recover within a short period of time, about 3 to 5 days. But no doubt, if the injury is more severe, more prolonged, then the recovery is going to take much longer. Most of us will say that we are going to go into recovery. That's what we keep on telling ourselves when we see an AKI. It's okay, I can manage. I'm going to go into, my patient is going to go into recovery. Yes, you can see the first picture. If you are a healthy young person, that's what I would hope for. But the problem is most of our patients who come in with AKI, they fall under this cohort where they can be elderly, they have lots of comorbids, they are aging patients. So this definitely will put them at risk of later CKD, end-stage kidney disease, and of course death. So KDIGO really tried, to finesse this whole thing. Okay, so they felt that AKI, the first 3 stages, can go into early recovery, and if it's transient, it may recover completely. But then AKD sets place, so you can have a late recovery, and even if that fails, then you're going to progress to CKD. Other potential sequel is going to be death. Mortality is something that we know. Development of hypertension, proteinuria. Proteinuria is quite a key indicator here. I know most of us believe that we should not be sending maybe a urine proteinuria just to, we do not want to check for the urine protein creatinine ratio or albuminuria when someone is ill. But in an AKI patient, if you've already found out that they have albuminuria or proteinuria, this indicates quite a bad marker for future, meaning the possibility of them to remain being proteinuric is there, but maybe the level is slightly less. And of course, CKD, and as I've mentioned earlier, if you are beyond the age of 65, you have about 6.7 times likely to develop CKD within the next 2 years. And those requiring dialysis, there is a 28-fold increased risk of stage 4 and 5 for the next 8 years. So this is what you can tell your patients when they ask you, or the family when they ask you, what will happen? Will I be dialysis dependent? Will my AKI recover? So always bear in mind, especially those received dialysis may fare worse. So again, why is AKI important and the consequences of AKI? So you can see there can be increased mortality, risk of developing CKD. They stay much longer, an average about 4.7 days longer as compared to the rest. And there is a significant financial burden to healthcare services. But this is something I want to share. So 2 different patients having similar insults, but they're going to react differently. Why? More and more people are looking into genetics. They are looking into nucleotide pleomorphism, okay? Meaning that they are looking at all levels, including cellular level and even the renin-angiotensin system. So overall, when there is differentiation of DNA, so your AKI consequences may differ between all. So if they are not recovering, in terms of non-recovery of risk factors, is similar to the risk of factors of AKI. So now we are coming to the part where you are now recovering. Patients are recovering from AKI. So what are the things that you want to look out for? So there will be lots of excessive water, electrolyte loss. So make sure that we replace them adequately. And most importantly, avoid insults. These are tandem AKI. So you want to avoid hypotension, hypovolemia, and if your patient has got fever, please do treat. And for me, I do not discharge any of my patients until the diuretic phase is stabilized. But if you are under dire desire of discharging them back home, make sure that they have and being taught about IO diary, input-output, and bring them back to the clinic to check their urea and creatinine. So now, once the nadi creatinine has been reached, okay, I'm already towards the end of my talk, okay, just bear with me for a few more minutes. Do we actually discharge patient once we feel that they are back to their baseline? No, you're supposed to keep them under a regular follow-up, but it doesn't matter where you keep them. Either you keep them at your tertiary center, you send them to clinic kesihatan, send them to private practitioners, but make sure that we always check their blood pressure, proteinuria, serum creatinine, and then by the end of the 3rd month of AKI, make sure that we look at complete resolution of AKI, whether we can detect a new CKD or worsening of the pre-existing CKD. So what's new here? How about biomarkers? So you can see, I deliberately made this slide very, very busy. So what I'm trying to say is that, first of all, there are a lot of biomarkers that have been looked into. When we speak about biomarkers, they are different from creatinine. Creatinine is actually, creatinine shows the functional of the kidney, the function of the kidney. But biomarkers, they come from a kidney. They are produced from a kidney injury. So they are more of a injury marker rather than a functional marker. So with this so many different types of biomarker, the question that I'm going to put up here is, how is it going to help in preventing AKI? So we are still looking into it. We know that there can be an early detection. So it's going to help us look much faster into this group of patients again and try to prevent further insults in them. So as we know, creatinine only increases 1 to 2 days after an insult. Okay, as I mentioned earlier, so the GFR is going to go down first. So at this point of time of subclinical AKI, so these biomarkers could be helpful by indicating there is a subacute kidney injury just hours after an insult. So as you can see here, there are different types of biomarkers. So one can be from the markers of glomerular function, example cystatin C, markers of the inflammation and repair. So this is going to be calprotectin. Markers of tubular damage, there's Engel, Kim-I, markers of all the cell stress. So there's IGF-P7, which has been spoken quite a bit about. So all this has been demonstrated to be quite sensitive as compared to the other markers. All right, so I come to the end of my slide now. So together, let's all try to prevent and stop AKI. So that's about it. Thank you.
Thank you very much, Dr. Premila, for giving me a great revision on acute kidney injury. I guess from the biomarker point of view, we still haven't found the renal troponin, like your troponin for non-STEMI yet.
Yeah, totally agree with that.
So I have a question from an anonymous attendee. Hi, doctor. Can you explain more about management in cardiorenal syndrome or how to manage AKI in patients admitted for decompensated heart failure and clinically overlooked?
Okay, to be honest, cardiorenal syndrome is one of my favorites. So most patients are going to come in, they're going to come in as heart failure. So at this point of time, I think it's important for you to really distinguish which type of cardiorenal syndrome is going to be, whether it's going to be type 1, 2, 3, 4. All right, but the mainstay of it is definitely going to be about offloading your patients. So you just have to be a little bit careful when you start administering all these diuretics to the patients. Keep them on check, meaning that make sure that their blood pressure does not drop way too much. Make sure that we check on their weight on daily basis. But along the way, I do understand that we might find that the AKI, so-called the kidney injury, tends to worsen. So the creatinine will start creeping up. I believe that's what you want to know. So the creatinine starts creeping up. So at that point of time, it is good for you to step back and look back and think what is causing the creatinine to go up. A few possible reasons here. A lot of us would like to say that this is over-diuresis. So I practically caused a pre-renal AKI. But in order for over-diuresis to occur, it will not be about you get a negative balance about 1 liter per day. No, it's not about 1.5 liters per day, but you have to have a huge amount of urine that comes out, and the total cumulative balance may be about negative 8 to 9 liters. That will practically make someone being volume depleted. So that is one possibility that you have to look into. Number two, I think we really have to look if this could be high dosing of furosemide itself causing to have acute interstitial nephritis. Again, I think when we look at the diuretics, furosemide especially, It was rather quite rare for it to actually cause AIN, but there were cases. And thirdly, look at other nephrotoxic agents that could have contributed to the AKI as well. So overall, I think it's mostly in cardiorenal. It's about offloading patient, because when you reduce the preload, you let the heart work better. So there will be more cardiac output. There's going to be more perfusion to the kidney. Similarly, some of them may even come in with this huge ascites. All right. So that is going to cause an intra-abdominal pressure. And we have even did a peritoneal tap for a few patients, because when you release that intra-abdominal pressure, kidney perfusion will also increase.
I guess I'll add a bit to that, because one of the pathogenesis of acute cardiorenal syndrome is probably reduced perfusion is one of them. But please don't forget about venous congestion. If someone is very overloaded, you have venous congestion as well. Sometimes you will notice that even if you give diuretics and there's a lot of urine output, sometimes the creatinine actually improved. And to begin with, the creatinine could not be the real creatinine to begin with, because when we have fluid overload, the initial creatinine during admission might be just a dilutional effect, and it's falsely low. When you offload the patient and become euvolemic, and the new creatinine, which is higher than the baseline, might be the real or the correct creatinine level.
Yeah, that's absolutely right. Yeah.
So I guess if there's no other question, and just to keep the discussion alive, I guess there's still some time. I would like to get the other panel's opinion as well regarding renal replacement therapy in acute kidney injury. I guess Dr. Primella did not mention about that, because it can be quite controversial at times. Just would like your opinion regarding SLAT versus CRT. Since Dr. Primella, you're the speaker, can I get your opinion first?
Okay, so SLAT versus CRT, when it comes to an acute kidney injury, I think it's going to be mostly based on hemodynamics. If somebody comes in hemodynamically unstable, then I would actually go for CRT. No doubt CRT, we don't routinely run CRT in a lot of our government hospitals. I guess that's because it's cost consuming. Even at our private hospitals, I think that's also another limiting factor. So ideally, in a patient who comes in, who's hemodynamically compromised, then I would actually give a CRT. For better, faster clearance of all the solutes, obviously SLAT will be the better option here. And again, when it comes to, for example, acute kidney injury, in cases of lactate acidosis, so if you ask me whether SLAT would do it better for clearance or whether it's going to be CRT, so I guess SLAT will be a better options here.
Okay. What about urine output? Do you think that CRT will be better than SLAT or PERT in the old term, in view of, in the sense of preserving urine output or earlier recovery of urine output? Because of the continuous nature of CRT versus the intermittent nature of SLAT itself.
Okay, whenever we prescribe a SLAT prescription, okay, so I think we've already put up our ultrafiltration rate that will be approximately, depending on the body weight of the patient, so it can be about 2.5 to 3. So this is going to be quite an abrupt removal of fluid that can lead to a reduction of urine output, further reduction of urine output in patients, as compared to if CRT, then I believe that you will be able to start very slow and the amount of volume of extraction will be much lower. And definitely, I think we have to keep it between 8 to 10 mils per kg per hour at this point. What do you think, Ong? How would you look at it?
I think personally for urine output preservation, personally I would prefer CRT, because I have some experience with this type of patient. When I prescribe CRT, even with a single inotrope, I guess sometimes in government hospitals, single inotrope, we tend to use SLAT instead of CRT. However, in private practice, we kind of have the freedom to do certain things that we believe in. So sometimes when I prescribe CRT, right, I notice that the uric output tends to recover faster
Okay.
as per SLAT. I think, as you know, I think a lot of trials showed that there's no difference between SLAT and also CRT. Yeah, but the problem is, I think these days when we prescribe SLAT, it's 6 hours, right? As compared
6
to
hours.
previously, it's more towards 8 to 12 hours. I personally believe that our SLAT currently has become more of a intermittent HD compared to nearer towards CRT as prior due to time constraint or cost constraint.
Yeah, I think definitely like as you said, that in private setting, even if patient comes in with single inotrope, I tend to do CRT for them more than SLATs. They fare better. They fare better, especially those come in with cardiac events and all. So yeah, they do fare much better. Recovery, I do see better recovery, faster recovery in them.
Okay. Any other questions from the floor? If don't have, Dr. Kelvin, do you mind if I end the session?
Yeah, sure.
All right. Thank you very much again, Dr. Primela, and thank you very much again, College of Physicians Malaysia, for organizing this for all our benefits. Thank you very much.
All right, thank you.
All right,
Thank you.
bye-bye.